Hello, everyone, all the esteemed faculty members. Very good evening and a warm welcome from Merck. I am Dr. Shilpa Subramanian, the medical manager for oncology at Merck India. Welcoming all of you. Thank you so much for taking out the time from your busy schedule for discussion on the individualized treatment approach in recurrent or metastatic head and neck cancer as per the clinical presentation. Next slide, please. So Merck, as we all know, is the world's oldest pharmaceutical global specialty innovator. It was founded in 1668. It's across 350 years plus, across 66 countries globally, as Merck has been established as one of the oldest pharmaceutical organizations. So when we come to what we do per se, there are three verticals that Merck has. One in healthcare, the other in life science, and the third one in electronics. The focus of healthcare majorly are patients, as patients are the center of our work. And the healthcare vertical has oncology, cardiovascular metabolism and endocrinology, neurology and immunology, and fertility as the franchises. With life science, there is genome editing, food and beverages. With electronics, there is future mobility, smart technologies, etc. As electronics franchise aims to create a vibrant world in Merck specialties. Next slide, please. So when we come to the healthcare portfolio, basically when we come to the oncology portfolio, we have an innovative oncology portfolio and the three molecules such as cetuximab, avelumab, and tepotinib. So cetuximab majorly is for metastatic colorectal
Recording in
carcinoma.
progress.
In recurrent or metastatic head and neck cancer and locally advanced head and neck cancer. Avelumab is for metastatic urothelial cancer, for advanced renal cell carcinoma and metastatic Merkel cell carcinoma. And the third molecule per se is tepotinib, which is for MET exon 14 skipping metastatic non-squamous cell lung carcinoma. Next slide, please. So with this, I'll invite all the esteemed faculty today evening. So Professor Yu Che Su, sir is the Director Division of Hematology Oncology in our hospital. Professor Ai Shu University, Kaohsiung, Taiwan. Dr. Kshitij Dumadia, who's a consultant medical oncologist of SCCHN Cancer Center, Ahmedabad, India. Dr. Pinaki Mato is a consultant medical oncologist at HCG Cancer Center, Vadodara. Dr. Shekhar Patil, consultant medical oncologist at HCG Cancer Center, Bangalore. Dr. Satish CT, consultant medical oncologist at HCG Cancer Center, Bangalore. Dr. Ravi Tippaswamy, consultant medical oncologist at HCG Cancer Center, Bangalore. Dr. Shantanu Paintse, he's a consultant medical oncologist at HCG Cancer Center, Nagpur, which is in Maharashtra. Dr. Samket Kotne is the consultant medical oncologist at HCG Cancer Center, Visakhapatnam, Andhra Pradesh. And Dr. Shashank Das, a consultant medical oncologist at HCG Cancer Center, Kolkata. Next slide, please. So with this, I'll present the agenda for the day, where we have a discussion on the epidemiology and characteristics of Indian scenario, followed by Taiwan scenario, followed by a panel discussion on the individualized treatment approach in recurrent metastatic squamous cell carcinoma head and neck as per the clinical presentation, followed by a small conclusion and a summarization. Next slide, please. So with this, I wish you all an engaging meeting, and I would like to invite Dr. Kshitij Dumadia, sir, for your presentation for the epidemiology in the Indian scenario. With this, I hand it over to you, sir. Thank you so much. Sir, are you speaking? I think there is some issue with the audio.
So you'll be sharing the screen?
Am I audible now?
You are
So you're
audible, sir.
audible.
Audible, huh? Okay, okay, fine, fine. Okay, fine. Okay. Just take my liberty to share the screen. Not able to share. Okay, yeah. Is it visible?
Yes, sir, it is visible now.
Great, great.
Yeah, just put it full screen, sir.
Yes, yes, fine. Good evening, everyone. Thank you, Mark, for this wonderful opportunity to interact with Professor and everyone. My
Sir,
job
we
here
cannot see in the full screen, sir.
not yet. Okay. Uh, what about now?
No, no, it won't
Not
be
yet,
able to
sir.
see
So
in.
in the bottom, just in the bottom on the right hand side, you will
Okay.
find an icon next to the volume button on the left hand side.
Mm,
So would you like us to share the screen instead?
Yeah, okay, fine. That will be fine. It's okay.
Okay, Nirav, can we do that?
Yeah, I'll do it.
Okay.
Sir, I hope you can see the screen.
Yes, yes. I'm able to
Okay.
see.
Yes, yes.
Thank you. Thank you. Okay. Fine. My job over here is to present the epidemiology and characteristics of head and neck cancer in the Indian scenario. Next slide, please. As per the recent Globocan 2022 epidemiological data, lip and oral cavity cancers, they are the second most commonest cancer, second only to breast cancer. If we see the epidemiology of head and neck cancers in India, lip and oral cavity, they are the commonest subsite amongst all other subsites of head and neck malignancies, with about 1.3 lakh new patients per year. In nutshell, oral cavity, it constitutes two-thirds of all the Indian head and neck cancer patient population, and out of which buccal mucosa and tongue, they are the most commonest sites to be affected. Next slide, please. This chart mentions how Indian head and neck cancer patients are different from the Western counterparts. The most common or the most important difference is regarding the subsite. In Indian setting, we commonly see oral cavity as the most commonest head and neck subsite involved, especially the bucco-gingival region. While in Western world, we see a lot of oropharynx and other sites which are commonly involved. If you look into the etiology of the head and neck malignancies in India, particularly chewing tobacco is very common. There are other forms as well, smokeless tobacco, erica nut, betel quid, but chewing is more common in India compared to the Western world, where smoking is common. If you look into the HPV prevalence compared to the Western world, Indian scenario show a less prevalence of HPV, about 7% versus 21% in the Western world. If you look into the stage of presentation, generally because of various reasons, we see a lot of locally advanced head and neck cancers compared to the cancers in Western world where early stage cancers are predominant. We look into the aggressiveness of the disease. Indian head and neck cancer patients, they seem to be more of an aggressive biology, more we see a lot of symptomatic patients, a lot of patients coming up with locally advanced stages versus the Western counterparts. Most of them, or many of them, are nutritionally compromised. They have many other comorbid conditions, and particularly they are younger. We see a lot of young, that is less than 40 years of age, head and neck cancer patients. In a nutshell, Indian head and neck cancer patients are different in many aspects as compared to the Western world. Next slide, please. So, as mentioned, oral cavity is the most commonest subsite, and it is common in patients below 40 years of age. What we see is oropharynx and larynx. It's more common in patients above 40 years of age. About 85-90% of the patients with head and neck cancers, they are exposed to tobacco. They are tobacco users, with chewing being the predominant style of tobacco using. Among oral cancers, tobacco users have shown poor survival, obviously, and reduced response to treatment than non-tobacco users. So, in short, we have that poor biology of head and neck cancers, which is more predominant in the Indian context. The risk of progression or mortality, as well as the risk of second primary, increases by 1% and 1.5% respectively for each year of tobacco use. And we see a lot of second primaries, we see a lot of, that's why we see a lot of recurrences as well. So, as compared to the Western world, these patients require an aggressive treatment and treatment which is a bit different from the Western world because the epidemiology and the causative factors, they are quite different from the Western world. Next slide, please. So if you look into the risk factors, I think the most common is we all know how common tobacco is. Chewing, as I mentioned, is more common. There are other different risk factors, as mentioned, reverse smoking, alcohol, poor oral hygiene, HPV. So all these are the risk factors associated with head and neck cancers. Next slide, please. So this summarizes how to evaluate and how to diagnose an oral cavity tumor. I'm not going into much details about it, but I do want to highlight this. The major problem in developing countries is the stage at which the diagnosis happens. Generally, it is in locally advanced stages, generally in later stages. And I think that is the reason by which we see about two-thirds of our patients are locally advanced uh, in our clinics. So that is what adversely affects the treatment outcomes, and that's why we need a treatment which caters to this specific need. Next slide, please. So as mentioned, they do present in an advanced stage with bulky tumors and symptomatic burden. About 80% of the Indian recurrent metastatic head and neck cancers, they have a very high tumor burden. They are quite symptomatic. These are a few of the pictures of head and neck cancer patients. Uh, this is this is what we actually see in our clinics. This is how they present. So in short, we see a lot of locally advanced head and neck cancers, cancer patients at presentation. Next slide, please. So the commonest tumor site is there in oral cavity, and in oral cavity, gingiva buccal region and tongue, they are the two most commonly involved subsites. And most of these patients, they present in a locally advanced or a metastatic stage, making their treatment more complex, expensive, and various other functional and cosmetic reasons or deformities that do happen. Recurrent metastatic head and neck cancers, they are often commonly seen in Indian population as there is delay because of various reasons, especially various socio-economic constraints. Next slide, please. So, despite the various treatment modalities available, the overall 5-year survival rate after treatment of oral cancer, all stages included, it's around 50%. Recurrences are also very common. Loco-regional recurrence is the most common cause for treatment failure known to occur in about 35% of the patients treated for oral cancers. And two-thirds of the patients with head and neck cancer recur, with most presenting in within 2 years after completion of the treatment for primary tumors. And what I want to highlight is there are many local regional recurrences which we are seeing in Indian settings. Next slide, please. So this was a paper from the Tata Group, very interesting one, which mentioned about the expectations and preference for palliative chemotherapy in our patients. So what actually patient wants, what is expected out of the treatment, and there are various parameters, and out of which what we can see is symptomatic relief is the primary expectation from our patients. Symptom relief was a primary expectation or an equally important expectation amongst all the patients which were studied into it. So symptomatic relief is one of the primary aims of treatment. Next slide, please. So to summarize, oral cavity constitutes two-thirds of the Indian head and neck patient population. They are quite different from the Western world with respect to their habits, the HPV status, the tumor size, the burden, and presentation. 80% of the Indian recurrent metastatic head and neck cancer patients, they have high tumor burden, they are symptomatic. The recurrent metastatic head and neck cancer, loco-regionally advanced one, is a staging which is most commonly seen because of various reasons. And with highly symptomatic cancers, obviously patient expectations should be considered, and symptomatic relief is the predominant goal, initial goal, apart from the other usual goals as well. So next slide, please. So I think with this, I stop my presentation, and I would again like to thank Merck and the entire team for giving me this wonderful opportunity. Thank you.
Thank you so much, Dr. Kshitij, for the wonderful presentation.
Yeah, welcome. Welcome. Yeah. Looking forward to the meeting, and let's see. It turned out to be a
Thank you, sir. Thank you for presenting the scenario of the Indian population from recurrent metastatic settings for head and neck cancer patients. With this, I would like to introduce Professor Yu Che Su, sir, for your session to present the epidemiology from a Taiwan perspective, sir. Over to you, sir. Thank you so much.
Hello, I'm Dr. Su from Taiwan, and I'm a senior medical oncologist here. And I also treat some. I treat that's about head and neck cancer, and I also treat some hematological malignancy like lymphoma here. So here I will present the epidemiology and the treatment consideration in Taiwan. And before that, I will have a brief introduce about the epidemiology of head and neck cancer in Taiwan. And I think the oral cancer Taiwan and India is quite nearly is nearly the same. We have a relatively younger patient, and we have a more blue collar worker who also have oral cancer. So I will present all of them in some of my case. Thank you.
Thanks a lot, sir. So with this, we'll be starting off the presentation. Nirav, can you please start?
Good evening. I'm Dr. Yu Jie-su, Director of Department of Hematology and Oncology at the Yida Hospital in Taiwan. I'm Professor of Medicine at Iso University. I'm delighted to be here tonight to discuss the epidemiology and some of the treatment challenges we face in Taiwan. This is the main content we will discuss tonight, starting with the epidemiology of head and neck cancer and some characteristics unique to Taiwan. And I will also briefly mention some of the problems we face with the special drug reimbursement situation by the National Health Insurance in Taiwan when treating head and neck cancer. I will then discuss some of the factors we should consider when treating patients, including the need for rapid responses, different disease status, and the importance of concept of treatment sequencing. Finally, I will present two of my own cases. First, I will briefly introduce the epidemiology of head and neck cancer in Taiwan. Head and neck cancer is a very important cancer in Asia. As this graph shows, Asia accounts for more than 60% of the world's cases of head and neck squamous cell carcinoma. In Asia, India has the highest number of head and neck cancer cases, more than 4 times as many as China. In Taiwan, there are about 8,200 new cases of head and neck cancer each year. However, head and neck cancer is a very serious disease in Taiwan. As you can see, the incidence of head and neck cancer among males in Taiwan is extremely high. The age standardized incidence rate is as high as 35 per 100,000 people, which is much higher than Mumbai of India, which is about 20. Moreover, the 5-year survival rate for head and neck cancer in Taiwan is relatively low. Even for stage 1 and 2 patients, the 5-year survival rate is only about 70 to 80%. At the stage 4, the situation becomes very grim, with a 5-year survival rate of only about 36%. In Taiwan, the most common type of head and neck squamous cell carcinoma is oral cavity cancer or oral cancer. According to Taiwan Cancer Registry, of the 8,200 patients diagnosed with head and neck cancer each year, oral and lip cancer account for more than 6,000 cases, a relatively high proportion. The annual mortality rate for oral cancer is also around 2,000, which makes it a major cause of cancer deaths in males. The reason why we have more oral cancer than oropharyngeal and hypopharyngeal cancer, it is mainly due to the specific lifestyle habit in Taiwan, betel nut chewing, which is a serious public health problem here. In addition, smoking and alcohol consumption are no risk oral cancer. Oral cancer is indeed a very serious disease in Taiwan, as shown in these graphs. The difference of average life expectancy between stage 4 oral cancer and normal population can be up to 18 years. For stage 3, the difference is 12 years. For male, the difference are 30 and 16 years respectively. Oral cancer causes severe life loss with advanced stage in Taiwan. In Taiwan, the current insurance policy primarily allows the use of cetuximab combined with chemotherapy, mainly PF4, as the first-line treatment of recurrent or metastatic head and neck cancer. In addition, from this year, monotherapy immunotherapy is also be reimbursed for patients with a CPS score of 20 or higher expression. For second-line treatment, we can choose Erbitux if patient had not yet received Erbitux before, or immunotherapy if the PD-L1 TPS more than 50%. But under Taiwan mutual exclusivity policy, only one of these two drugs can be used. Once one drug is used, the other is no longer reimbursed. So we often face the challenge of choosing between immunotherapy and cetuximab-based chemotherapy for the treatment of metastatic or locally recurrent head and neck cancer. Choosing between these two options is a challenge we face every day. Let's go back and take a look at the head and neck cancer patient we are dealing with. When treating patients with head and neck cancer, we need to consider the following factors. First, we generally favor a rapid response to treatment because most patients with recurrent or metastatic head and neck cancer have a very high tumor burden, and the patient grows very quickly, leading to severe symptoms. We also take into account the location of the cancer and the patient's physical performance status. We also need to consider the type of recurrence, which it is local regional recurrence or distant metastasis. PD-L1 expression is another important factor to consider. Finally, Resistance to platinum-based drug is also an important consideration when treating patients with recurrent or metastatic disease. Let's discuss the issue of drug selection when treating patients with recurrent or metastatic head cancer, especially consider the need for rapid response. In the treatment of head cancer, the tumor response is crucial. Once a treatment response is observed, it can significantly improve the patient's symptoms and prolong their life. In a previous sucker study, the addition of Erbitux resulted in a significantly faster treatment response and excellent local control. Patients who responded quickly also had particularly good survival. We can therefore see the patient who responds to cetuximab have a significant reduction in their overall VAS score, meaning that the improvement in swallowing, pain, and speech. So it is undeniable that patients who responds quickly had better outcomes. As we know, in KEYNOTE-012 trial, the overall response rate in patients with recurrent or metastatic head cancer treatment with pembrolizumab monotherapy is only 23%. In patients with smaller tumor, the overall response rate is about 36%. But in patients with larger tumor, the response rate is even lower as 14%. Therefore, the pembrolizumab monotherapy, the response is generally worse if the tumor size is large. This is a challenge in treating head cancer, especially if the patient had a large size with significant symptoms. This result often makes the use of immunotherapy difficult. In the KEYNOTE-048 trial, the extreme regimen was associated with higher overall response rate compared to pembrolizumab monotherapy, as well as a large and a more effective tumor response than immunotherapy alone. In addition, the high response rate was not influenced by PD-L1 expression. The disease progression rate for pembrolizumab alone is as high as 32%, even with a CPS greater than 20. However, compared to pembrolizumab monotherapy, the PD rate was significantly lower with the extreme regimen. Comparing extreme regimen with pembrolizumab plus chemotherapy, the response rate in the CPS more than 20 group was slightly higher with pembrolizumab plus chemotherapy, but the PD rate was also higher. In fact, in the CPS less than 20 group, cetuximab plus chemotherapy significantly outperformed pembrolizumab plus chemotherapy in terms of overall response. Therefore, in KEYNOTE-048, the extreme regimen showed a clear advantage over both pembrolizumab alone and pembrolizumab plus chemotherapy in terms of overall response. Next, we need to consider factors when treating recurrent or metastatic head and neck cancer, including the location of the tumor and the nature of the recurrence, such as whether it is local, regional, or distant metastasis. These factors require detailed assessment and consideration. In fact, in the extreme, TP extreme and KEYNOTE-048 trial, the proportion of patients with oral cancer is not high, only about 20 to 27%. Conversely, most patients have oropharyngeal or hypopharyngeal cancer. Of course, this is the case in European American. In regions such as Taiwan and India, the incidence of oral cancer is actually much higher. However, going back to extreme trial, the subgroup analysis show that patients with oral cancer actually benefit more. Oral cancer had a significant advantage in the extreme trial with a median overall survival of 11 months compared to 4.4 months in control. It appears that oral cancer responds very well to cetuximab in combination with chemotherapy. Unfortunately, there was no subgroup analysis based on tumor location in the KEYNOTE-048 trial, and overall survival was not segmented in this way. Therefore, current data suggests that oral cancer may have a better survival benefit with cetuximab plus chemotherapy in the extreme trial. Another aspect that can be analyzed is whether the patient has local regional recur or distant metastasis. In the extreme trial, about half of the patients had local regional recur, while the other half had metastasis or a combination with local regional recurrence. In TP extreme, 35% were local regional, and 42% were only metastasis. In KEYNOTE-048, local regional case account for only 30%, and about 70% were metastasis with or without local regional recur. The KEYNOTE-048 trial showed that treatment with pembrolizumab alone or in combination with chemotherapy appear to be more effective in patients with metastatic cancer. However, in our head and neck cancer patients, especially oral cancer patients, local regional recurrence is more common. Metastatic disease seems to respond better to immunotherapy combined with chemotherapy, but the situation is not the same for local regional relapse. Local regional recurrence is a common problem in oral cancer. According to the data from KEYNOTE-048 trial, analysis of tumor location suggests that the cetuximab chemo group had a clearly advantage in responding to local regional recur in oral cancer compared with the use of immunotherapy alone. When comparing immunotherapy in combination with chemotherapy with cetuximab chemo group, both treatments appear to be equally effective for oral cancer patients. Therefore, for patients with oral cancer, cetuximab combined with chemotherapy may be an appropriate treatment choice. Of course, immunotherapy combined with chemo is also an effective option, and both treatments have been shown to give good results. In addition, from a cetuximab-based treatment perspective, in patients with local regional cancer, cetuximab in combination with chemotherapy show consistent results in studies such as EXTREME and CHANGE-2 trial. Cetuximab plus chemotherapy had an even greater advantage for patients with local recurrent cancer. In fact, local recur is the most common scenario for oral cancer patients. In such patients, opting for a cetuximab-based chemotherapy regimen is the best choice, as the evidence-based results support the approach. Based on this, we have conducted some related study in Taiwan. This is an analysis looking at the effect of cetuximab-containing regimen in local regional recurrent and distant metastatic head and neck squamous cell carcinoma, and whether there are any differences. In this study, about 50% of patients were diagnosed with oral cancer. Of course, of these, 60% had local regional recurrence, while only 34 had distant metastasis. This suggests that local regional recurrence is the primary scenario in oral cancer. In contrast, patients with oropharyngeal and hypopharyngeal cancers are more likely to experience distant metastasis. Therefore, it is important to pay special attention to local regional recurrence in common oral cancer. In this study, patients with local regional recurrence who received cetuximab had a better overall survival of 15.5 months compared to 9.7 months for patients with distant metastasis. Progression-free survival shows a similar trend, with 5.8 months for local regional recurrence versus 4.2 months for distant metastasis. Therefore, cetuximab treatment does provide a greater benefit for those with local regional recurrence. The disease control rate is 62.5% in patients with local regional recurrence and only 45% in patients with distant metastasis. Although the number of cases with distant metastasis is smaller, the trend in the p-value indicates a significant advantage in use of cetuximab for the treatment of local regional recurrence. They also made comparison in two other scenarios: cases with local regional recurrence only, cases with distant metastasis only, and cases with both. The comparison clearly showed that patients with local regional recurrence only have a greater survival benefit when treated with a cetuximab-based regimen. Using Cox regression analysis to examine overall survival and progression-free survival, it is clear that both univariate and multivariate analysis, patients with disease recurrent, local regional versus distant metastasis, show significant advantage in terms of overall survival and progression-free survival. Therefore, among patients treated with cetuximab, those with local regional recurrence do indeed have a comparative advantage. So why do you have to discuss this issue all the time? Under contract of Taiwan National Health Insurance, we usually have only one choice and one chance when choosing first-line drug, either cetuximab or pembrolizumab monotherapy for patients with CPS more than 20. Faced with the either situation, we often have to make difficult choice. So how should we choose to improve patient outcome? We need to consider not only the first-line treatment, but also its impact on subsequent therapies. For example, we are currently considering several options. The first is Erbitux plus chemotherapy followed by immunotherapy. The second is to start with immunotherapy followed by Erbitux plus chemo. However, this regimen is not supported by clinical trial evidence, with current evidence mainly supporting the first sequencing. The third option, which involves deciding which drug to use after immunotherapy and chemo, also lack clear evidence. If pembrolizumab plus chemotherapy is chosen first, the choice of subsequent drug remains an unsolved issue. These are currently no clinical trial looking at this. In the KEYNOTE-048 trial, we also observed some patients who experienced progression-free survival but following subsequent treatment. The median overall survival with pembrolizumab plus platinum-based drug and 5-FU was 13 months, while the median survival with subsequent treatment with cetuximab was 22 months. Patients who received extreme regimen in the first line followed by immunotherapy in the second line has a median survival of about 16.5 months. In TP Extreme trial, those who received cetuximab plus taxane and cisplatin, the median survival with second-line immunotherapy is 21 months. However, the patient who received cetuximab plus PF regimen, the actual median survival is 19 months. This finding addressed the question of treatment sequencing, which is not solved in current clinical trial. And how about combination of both drugs? This is a very interesting study by Dr. Lian in Taichung. Whether it is more beneficial to use combination therapy or sequential therapy, especially can cetuximab be combined with immunotherapy, and would this approach potentially improve survival? This study collected data from 219 patients who received first-line cetuximab-based treatment, including 128 platinum refractory cases and 162 platinum-sensitive cases. Some of these patients received immunotherapy, while another group did not. For those who received immunotherapy, we further divided them into subgroups based on whether they received cetuximab in combination or sequentially. About 60% patients have oral cancer. Comparatively, the best response to cetuximab show an objective response rate around 42%, stable disease of 28%, and disease control rate of 70%. The real-world results are very similar to those seen in the extreme trial. In this group of patients received first-line cetuximab plus chemotherapy. Those who also received immunotherapy had a better overall survival than those who did not. The median survival for patients who received both drugs was 20.6 months, compared to 9.1 months for those who received only one drug, highlighting the importance of using both drugs. In a group of patients who received cetuximab plus chemotherapy as first-line treatment, there appeared to be a response rate of about 51% when immunotherapy is added. However, when cetuximab is combined directly with immunotherapy, the response rate is not so good. It's only 42%. As we can see in this graph, about immunotherapy after cetuximab or in combination, there is some trend of difference between them. It seems that the sequential
This
approach
institution
is
is like
slightly
AIMS,
better
PI,
than
or
the
GIFAR and
combination
other government institutions,
approach,
like
but the
RPCM.
p-value is 0.8.
ಬರೋದಕ್ಕೆಲ್ಲ ಆಸಕ್ತಿ ಆಗಬಾರ್ದು ಯೂಸಿದ ಬರದೇ ಇಲ್ಲ
In my opinion, subsequent usage is at least the same or maybe better as combination use. About which one go first? The team at our hospital has published a paper based on clinical situation about 2 years ago, comparing the sequencing of cetuximab followed by immunotherapy versus immunotherapy followed by cetuximab in patients with head and neck cancer. The study analyzed real clinical cases to investigate the outcome of this treatment approach. This study included a total of 75 patients. Half of them received immunotherapy followed by cetuximab-based treatment, and the other received cetuximab-based treatment followed by immunotherapy. This group consisted 35 and 40 patients respectively. Among these cases, patients with oral cancer predominant. The primary endpoint analyzed were overall survival, first progression-free survival, and second progression-free survival. In terms of overall survival rates, the group received cetuximab first had a overall survival rate of 73%, while the immunotherapy group had a rate of only 37%. In the group that received cetuximab followed by immunotherapy, the complete response rate was 20%, while the group that received immunotherapy followed by cetuximab, the complete response rate was only 6%. The significant difference suggests that in the real-world data, cetuximab plus immunotherapy followed by immunotherapy appear to have a significant advantage in terms of overall survival. In second-line treatment, response tend to be better in the group that received cetuximab followed by immunotherapy. At this stage, the overall response rate for cetuximab followed by immunotherapy was 63% compared to 37% for immunotherapy followed by cetuximab. Frankly, starting with cetuximab followed by immunotherapy seems to be a better choice. After the analysis, the treatment sequence for overall survival and the progression-free survival did not have significant impact. Even in terms of PD-L1 expression, whether it is high or low, there is no significant difference between these two treatment sequences. The only difference is that using cetuximab in the first line gives a better response rate, even if immunotherapy is added later in the second line. It can still maintain a 63% response rate, which is better for patients with high tumor burden in terms of disease control. So, although there is no clinical trial directly comparing cetuximab followed by IO or IO followed by cetuximab, based on recent clinical trial, including TP Extreme trial and retrospective study in Taiwan and other countries, we can see that using cetuximab plus chemotherapy in first line followed by immunotherapy in the second line give a median overall survival of about 17 months to 20 months. This is actually quite a good outcome. The sequential approach to treatment seems to make sense. In addition, for patients who fail immunotherapy, continuing with cetuximab can also provide significant benefit. Second-line treatment with cetuximab can extend survival by at least 9 months. The patient with head and neck cancer will benefit more if they have received Erbitux and immunotherapy-based treatment. Finally, let's share my two cases. The first case is a 72-year-old male with hypertension, diabetes, hepatitis B, and a history of smoking and bitter nut chewing. The patient was diagnosed with buccal cancer in 2013 and underwent surgery. It was stage 2 at that time. It's about 10 years ago. Like the oral cancer patient we encountered, the patient experienced recurrent in 2016 and February 2023. The recurrent in February 2023 was stage 4 T4A. As a result, he underwent radiotherapy. Unfortunately, less than 4 months later, there was another recurrence, and we performed a tumor resection with a PD-L1 CPS 0. We started treatment with cetuximab plus PF4, the extreme regimen, from October 2023 until now, and his current condition is still good. The patient was also diagnosed with liver cancer concurrently. Biopsy revealed hepatocellular carcinoma with a CHOP score only 5 due to the patient's advanced stage and the recurrence of head neck cancer. Surgery of liver cancer was not an option. Therefore, the patient also underwent TACE. It's fortunate that the patient achieved a partial response in both tumors. Is currently still receiving cetuximab treatment. Regarding the tumor cancer, we continue monitor it closely with TAC scheduled every 3 months. Both cancers are well controlled. In Taiwan, we always use extreme regimen Erbitux PF4 in our recurrent metastasis head neck cancer patients who need to be treated. TP extreme may also be considered in patients but in patients with poor liver function, the hepatological toxicity is relatively high. Our number 2 case is a 62 years old male who smoked, he told not chewing, and drank alcohol. In 2020, he was diagnosed with hypopharyngeal cancer. He underwent partial pharyngeal lumpectomy as he was stage 4B at that time. For post-op, he received CCRT and then 1 year of oral U4 treatment. Unfortunately, a tumor was noted in his lung, and subsequent PET scan revealed metastasis through his body. Lung biopsy revealed also metastasis squamous cell carcinoma with PD-L1 CPS only 1. He was therefore classified as stage 4C. He was treated with a cycle of cetuximab plus PF4. The patient's tumor initially showed widespread metastasis on PET scan. However, the tumor shrunk rapidly after extreme regimens and achieved very good response. We gave him local radiotherapy for the residual tumor in the chest, and currently the patient is maintained treatment with oral U4 and he received regular follow-up. Finally, let's summarize the key points and give you some take-home message. Firstly, in terms of treatment, cetuximab-based regimen have a better proportion of faster responses compared to single immunotherapy or immunotherapy combined with chemotherapy. Secondly, in oral cancer patients, local recurrence is more common than distant metastasis, and cetuximab-based treatment have an advantage in controlling local recurrence compared to immunotherapy. In terms of treatment sequence, cetuximab-based treatment followed by immunotherapy seems to improve object response rate and disease control rate for first-line treatment. Moreover, we still recommend adopting sequential treatment. Combination treatment does not provide a better survival benefit. This concludes my presentation, and thank you for your listening.
Thank you. Thank you very much, Professor Su, for the wonderful presentation. Thank you.
Okay.
So with this, I would like to invite Dr. Pinaki Mato, consultant medical oncologist for HCG Cancer Center, Vadodara. Sir, over to you for your panel discussion. So would you like to share the screen?
Yeah, good evening. So I'll share my screen.
Okay, sir. Over to you, sir. Thank you so much.
Is my screen visible?
Yes, sir.
Yes,
Yes.
yes, sir.
Please go ahead.
Just one minute. I think all my panelists are there on board. So thank you, Mark, for organizing this lecture. It's very nice to see a international speaker come and talk about a cancer that we encounter so commonly and elucidate the guidelines definitely, but also the practical points that we see on a day-to-day basis and debate what should we do in our day-to-day practice. With that in mind, let us talk about individualized treatment approach in recurrent metastatic squamous head and neck cancer. Myself, Dr. Pinaki. So, Dr. Su, I would definitely like to be a part of this panel. And we also have oncologists across the length and breadth of India. So, we have Dr. Satish and Dr. Ravi. They are from the southern part of India, I think. Dr. Shashank is from the eastern part of India. Dr. Shantanu is also from the central part of India. And Dr. Samkit also from the central part of India. So, we will be discussing about the guidelines definitely. A lot of those things have been discussed, but we'll also like to discuss what our personal perspectives are when treating these difficult cancers. So we know that patients in India, as Professor Su has already discussed, we in India also see patients who have got bulky tumor and who are very symptomatic. And these are patients who have a very miserable existence and need rapid amelioration of the symptoms when they come to us with such kind of presentations. And it is clearly shown that early response is key to symptom management, which in turn provides better outcomes. And as Professor Su showed that improvement in the quality of life parameters, in the swallowing, in the pain, all those are very important. So a drug that does that is probably one of the best drugs to use early in the management. Patients with large tumors may benefit. Again, this was shown by Professor Su that when you look at the subset analysis of Keynote 012, you find that patients who have tumors that are larger in size have got the lesser overall response rates and partial response rates. So immunotherapy probably is less effective in treating the larger tumors, is something that we should keep in mind. And most of our patients, when they come, they generally have bulky tumors which are very symptomatic. So if you talk about the first line treatment options for recurrent metastatic squamous head and neck cancer, we find that both the Keynote 048, that is pembrolizumab platinum 5FU, and mono pembrolizumab as well as cetuximab platinum 5FU. So both of them have been mentioned as category 1. So it is not that one is category 1 and one is category 2. I think this is the latest guidelines. So even the guidelines have not pointed out that this is the winner and we should use one over the other. So I think our personal knowledge and discretion in our particular patient should be used while we're individualizing the treatment. I think guidelines are guidelines and they should always be taken with a pinch of salt. We should use our own discretion when we're treating our patient. It is also shown that head and neck cancers are having an immunosuppressive microenvironment, and that probably is responsible for the not the very good responses with the immunotherapy that we traditionally see with other cancers. And this immunosuppressive microenvironment actually increases once the disease goes into the metastatic stage. Actually, if you look at the hallmarks of cancer, we know that evasion of the native tumor, native cell immunity is one of the mechanisms why the cancer metastasizes, and that is probably responsible for a more immunosuppressive environment in the metastatic setting. So patients, we know that they might have a high tumor burden and may need a rapid response. And when we look at the extreme trial, when we compare it to the Keynote 0, this was again shown by Professor Su that the overall response rates were lower and the progressive disease was higher in patients who received only monotherapy with pembrolizumab and had detrimental in recurrent setting in the Keynote 048. So here I would like to have the opinion of my panel members. Dr. Satish, how comfortable are you using pembrolizumab monotherapy in this setting?
See, like pembrolizumab monotherapy, I'll be considered in a low burden disease, indolent disease only. In a the patient was treated early, and I have a very small disease, lymph nodal disease. If not feasible for a surgery, still we'll go for any salvage surgery. All those. That setting up the patient, we'll try to use a single agent. Even though PD-L1 like a score, like a CPS score is more than like a 20%, like I'll be more like bulky disease, comfortable with the combination of chemo immunotherapy, or like the patient is short duration, like is a very aggressive, and previously like a history of immunotherapy, sometimes recurrent setting. That time I'll try to use the extreme is one of the other regimen I'll try to consider in my practice. Monotherapy very rarely be used, very indolent category of patients, low burden disease.
Okay, thank you, sir. Dr. Shantanu,
Sir, yes, sir.
what is your practice? In which patients do you feel that pembrolizumab monotherapy scores over cetuximab or even an extreme kind of regimen?
Sir, almost none. I mean, practically, I'm not using single agent pembrolizumab except when there is contraindication for therapy, such as some 78-year-old male with who's not fit for any other kind of therapy. Then otherwise, no. I mean, not at all. In fact, whatever PDL1 report we get, PDL1, in my opinion, is not a great biomarker. Whatever studies may say, in at least our patient scenario. What patients we are seeing, whatever PDL1, pembrolizumab does not necessarily work. So it is always chemotherapy plus pembro. If it is responding, we'll consider it continuing pembro monotherapy as maintenance.
Okay. Okay. Dr. Shashank, you have any thoughts on the CPS scoring when you decide whether to give pembrolizumab as a monotherapy or combination as compared to extreme?
See, from as per the slides you're showing, there are also the CPS score of more than equal to 20. There was around a 32% patient had progressive disease, and only 23% have been a response with pembro monotherapy. So it's a very dicey situation giving a single agent pembrolizumab in a patient of greater than CPS score 20 without chemotherapy. And the most important thing, if the patient is having a bulky disease, and in those even a small amount of disease progression might lose the I might lose the patient in those patients. So I don't currently use single agent pembrolizumab in my patient, except when if the patient is having a contraindication of chemotherapy, or if the patient is having a very small low volume disease, maybe a single lymph node recurrence, neck recurrence. In those patients with CPS score greater than 20, I might be using a single agent pembrolizumab, otherwise not.
Thank you, sir. Dr. Ravi sir, for patients who have a CPS that is somewhere in between, that is 1 to 19, do you prefer the combination of pembrolizumab chemotherapy or cetuximab chemotherapy?
Yeah, generally, as it was discussed earlier, our set of patients are biologically different. We see a lot of these tobacco-related large volume disease, and in our own experience, we have seen that whenever we give immunochemo, the chances of progression is or the chance of responses are less as compared to giving cetuximab and chemo. So we practice cetuximab and chemo in the first line setting, then followed by cetuximab maintenance, and those who progress, then we plan immunotherapy.
Okay. So actually in Keynote 048, they had a post hoc unplanned analysis of patients who had a CPS less than 1% and CPS 1 to 19. So in that, they actually showed that for patients who had a CPS 1 to 19, pembro plus chemo was statistically significant better survival. But again, in our setup, as we said, we have very different patients. Sir showed that only 1/4 of patients actually were oral cavity in that trial, whereas in our day-to-day practice, almost 60 to 70% of patients we see are actually oral cavity. Also, when we look at the forest plot here, we can see that clearly patients who had metastatic disease, they were the ones who benefited more. Whereas in our day-to-day practice, it is mostly the loco-regional recurrence patients that are much, much more common. And there, it is just on the fence to decide whether which of them is better. And probably we feel that cetuximab first would do better. So again, a CPS cutoff of 20 is arbitrary. I think in different malignancies, different cutoffs are done, and this is, I think there is no right cutoff to say that 20, more than 20, it is just what the trial took. But any views on this? Do you have any personal views on what cutoff of CPS you would use to decide to stratify between cetuximab and immunotherapy? Satish sir, do you have any
Yeah.
views on this?
See, then we are more well versed with our lung cancer study that CPS were more than 50. We are happy at least monotherapy with a strong PD-L1 positive low burden disease. We can try with the monotherapy. The cancer data is a more than 20% data for in head and neck cancer single agent monotherapy is there. But because of majority of our patients are they have bulky disease, many of us will landing up with the combination of chemoimmunotherapy we try to give rather than the monotherapy. I think it is individualized. We have to see that case to case basis, and you should see that. And if a young and fit patient is there fit enough to take combination chemo and immunotherapy, I think majority of patient you practice rather than monotherapy. Unless not fit and low burden disease CPS more than 50%, I think you can consider for the.
Okay. I think I would like to ask Dr. Professor Su here as well, because I think in Taiwan they have a very unique situation where they can use only one of the two, either Erbitux or immunotherapy. Sir, so do you believe in this CPS that if the more the CPS, you would more be keen to use the monotherapy, sir, with immunotherapy?
Yes,
Yeah.
I think the CPS is just like a cut-off rate, but in my opinion, I don't think a higher CPS mean more effective. And in Taiwan, we also try to use monotherapy pembrolizumab because it is reimbursement by our national insurance project. But unfortunately, in our experience for oral cancer patient, the effect's not so good. Yeah. So in my opinion, the CPS score only mean that above maybe 20, it is effective for monotherapy, but not more higher or more effective. That's in my opinion. Thank you.
Yeah. So the next question also for you as well. How frequently do you see this concept of hyper progression with immunotherapy? Is it very common or is it just a concept for you?
Yeah, it is a problem too because if we use the monotherapy, yeah, they will about maybe 10 to 20% patient will suffer from hyperprogression. And you can see the real world data in Taiwan national insurance project. Yeah, the progression condition, the progression time is not as high as the Kino 48. It's quite low. Yeah, it's not the same as the study.
Okay.
Yeah, because we have more oral cancer patient. Yeah, it's I think oral cancer patient is quite different from hypopharyngeal or pharyngeal.
Okay. Dr. Shantanu, have you seen cases with hyperprogression in your practice when you have used the immunotherapy in head and neck?
Yes, sir. Yes, sir. Even with nivolumab, we have seen, particularly some there is certain class of patients which I don't think it's quite common outside our region. Maybe Gujarat. Yes, sir. Gujarat must be there. Patients in their 30s. I mean, they're quite aggressive. In the fourth decade of life, those who are younger ones, they are. I mean, I have seen a few patients who are get hyperprogression even with immunotherapy. I don't know whether to call it as hyperprogression or it is truly a rapidly aggressive disease which is progressing. But yes.
Yeah. So I think hyperprogression is a concept. We still don't have strict criteria to diagnose what is hyperprogression and what is not. There are basically clinical and radiological criteria, but the mechanism of hyperprogression is not clearly understood. So yes, but it has been described with immunotherapy, and as Sir has said, and also our Indian colleague has said that yes, we see such hyperprogression cases, and these patients usually die off quickly. So there is nothing much that we can do for these patients. These are some of the criteria that might be risk factors that tell you about the response who might not be a candidate for using the immunotherapy. One of those criteria was the neutrophil to lymphocyte ratio, a ratio less than 5 actually was better for immunotherapy, and also the sum of the target lesion, that means the disease was bulky more than 4 centimeters, then definitely the role of immunotherapy was less. So how much do we believe in this, Dr. Ravi sir? Do you believe in this neutrophil to lymphocyte ratio or in the size? You feel that this might be one of the ways to stratify?
Yeah, probably, and we are not practicing. I don't know the practicality, but definitely larger lesions we have seen this immunotherapy, especially in endocrine malignancies. The response rates are less, and by the time 4 or 5 weeks have happened, the general condition of the patient will deteriorate, and they may not be eligible for further treatment. It may be a true progression or pseudo progression. So neutrophil lymphocyte ratio we are not using, but definitely the bulk of the disease is what we are using.
Okay. Professor Su, your thoughts on this? Do you look at the NLR when you are assessing such a patient?
Yeah, I think the study is the same as our experience because in a very high tumor size, yeah, the immunotherapy response is not good.
Yeah, the
And
P,
interestingly, we have some data also show that the neutrophil to lymphocyte ratio is also a good indicator for immunotherapy. Yeah, if the neutrophil annual ratio is too high, it's not a good predictor for immunotherapy. Yeah.
I think the p-value here is very significant for the NLR. And actually, NLR, not only for oncology, but in general, is a predictor of a poor survival if you have a high NLR. So I think this we can also have a look. This is very fascinating concept.
Yeah, Pinaki,
So,
hello.
yeah, yes, sir.
Yeah, definitely that another ratio. Most of the immuno-oncology trials, definitely it is one of the it is a prognostic factor. It tells that okay, they'll do well or they'll not do well. But in head and exam, we want to hear from professor also, because many of the patient they'll have a secondary bacterial infection, that is have a neutrophilia that will be there. Like, is it really that is comforting factor? Really, we don't know, and the use of antibiotic also might reduce the efficacy of immunotherapy also. We don't know really, but we should analyze and we should our data also. That's what. Yeah, but we are not generally we are deciding factor. We're not using what Ravi has said. Yeah, definitely should see that like low volume disease you can consider, high volume disease with combination chemo with immunotherapy. Yeah.
Great, sir.
Yeah.
So we saw here that basically it's a toss-up between the overall response rate and the overall survival. So whatever we believe in overall response rates. Cetuximab definitely seems to be a very good option. And if you believe in the overall survival, then probably immunotherapy. But yes, in immunotherapy, only subset of patients respond. So here you can see that whether you use an extreme regimen or you use a TP extreme regime, the overall response rates are very good, 50 to 60% in some of the trials we can see. And the median OS is also similar with what we saw in the extreme. Anybody has some opinion on whether to use the cisplatin 5FU or the taxane platin combination? Dr. Shashank, what is your day-to-day practice? Which one you prefer, cis 5FU or the taxane platin combination with cetuximab?
See, with the advent of the TP extreme regimen, and it is showing a overall similar efficacy compared to the extreme regimen. So in my practice, I only use the paclitaxel with cetuximab most commonly. Means unless the patient is a very fit patient is very young. In those patients, I might use the extreme regimen. Otherwise, the common practice is the TP extreme.
Okay. Dr. Shantanu, is this the same at your place?
Yes, sir, but almost on the same lines.
Okay. So I agree with him, and I think all of us have become so comfortable now using the weekly cetuximab with taxane and platin. Most of us use similar kind of protocol in our institutions. There are numerous real-world evidences that show that the overall response rate and the OS is good in Asian and Indian population, especially with this cetuximab and chemotherapy. And there is a significant symptomatic improvement. So this is something that we want, because most of our patients, when they come, they're very symptomatic. If we do not give rapid symptom relief, then even if the improvement in the survival, to make them understand that is very difficult. So there is a very good improvement in all the symptoms, especially when we start with cetuximab based chemotherapy. When we talk about oral cavity tumors, so again, this is an interesting question, that whether we stratify our patients based on the oral cavity versus non-oral cavity. Dr. Ravi, yeah.
So sorry to interrupt. Dr. Sanket Kotne has also joined us from the panel.
Okay. Yeah, Dr. Sanket?
Yes, I'm here.
Yeah. Dr. Sanket, do you stratify your patients based on oral cavity versus non-oral cavity to decide whether you want to use cetuximab or pembro?
More or less, in my practice, most of the times we do see oral cavities, and like what everyone had mentioned, like taking everyone's point uh, in the view. Uh, it's all based on the tumor burden, and I routinely use cetuximab with chemotherapy.
Okay, so you don't think that you don't use the origin, that is the oral cavity versus non-oral cavity, to decide whether to give cetuximab. Rather, the tumor size and probably
Yeah,
the symptomatology is more important
yeah.
for you.
Symptomatology matters. Yeah, for me.
Yeah. But as Professor Su showed that in the forest plot, that the patients who had a oral cavity tumor, they actually didn't really benefit by the combination of pembro and chemotherapy. So that is something that we don't know. It was not planned subgroup analysis, but it all keeps in our mind that whether this subset using cetuximab would be a very good alternative. So that's what has been shown here, that patients with oral cavity and recurrent disease probably would not benefit with the immunotherapy and chemotherapy. And we have numerous real world studies which have shown OS benefit using the cetuximab chemotherapy in the first line setting. These were some studies. I'll just go through them. This was by Dr. Bal from North India, and basically it was shown that the overall survival was more than doubled when cetuximab was added to chemotherapy in the oral subset. And this is so the benefit in the oral cavity actually was more than in the oropharynx. So this is something that we see in our day-to-day practice as well. And also there was a real world evidence from Kolkata and Delhi by Dr. Chandrakant, and it also showed that the patients had a very good response, especially in the oral cavity subset of patients. So that's why this, I think, to achieve better OS, which treatment, again, Professor Su has described this, but we can all share our individual experiences one by one. So, Dr. Satish, what sequence do you believe in?
Yeah, like bulky disease, oral cavity tumor, I'll go for a extreme regimen, or like we'll go taxane based with the cetuximab. I'll go. Then after that, I'll try to go for a immuno-oncology, like a immunotherapy. I'll be trying. And also one more thing is biomarker. If the PD-L1 is very high, that not like borderline, then I may think about the other way around. Okay.
Okay. Dr. Shantanu, what is your usual sequence?
So usually for at least oral cavity bulky, yes, it is cetuximab. Irrespective of PD-L1, sir. Another reason being patient is fit for chemotherapy, I prefer combining cetuximab. Nivo can be offered as single in subsequent line.
Okay.
Don't know, that is not a scientific reason, but I don't know, but it is practically fun.
Yeah. Another thing, Professor Su, I would like to ask your experience about combining cetuximab and immunotherapy, whether it be nivolumab or pembrolizumab. What has been your practical experience?
Yeah, we have some patients who receive a combined cetuximab and immunotherapy this year, but in our opinion, I think it's the toxicity is too high, and without chemo, the control rate is not so good.
Okay.
So finally, we use sequential use, and cetuximab followed by immunotherapy is our choice, because the only evidence base we have is the extreme followed by immunotherapy. We don't have any large clinical data about the immunotherapy followed by cetuximab. And our hospitals data also show that Abita followed by immunotherapy has a better overall outcome. So now we always use cetuximab best with chemo followed by immunotherapy alone in our hospital.
Do you find any difference in the progressions that you see after cetuximab versus after immunotherapy, sir? No. Okay. So I have used a combination of nivolumab and cetuximab in few of my patients, and so far I have got good responses. But as you showed clearly, the sequencing is probably would be a better way to go rather than the combination. I completely agree with that, sir.
Yeah.
Okay. And there is some mechanism to show that cetuximab using probably would make the tumor more responsive to immunotherapy in the second line. This is something that has been shown in terms of molecular pathogenesis. And this is phase 2 data that shows that we have a survival somewhere from 18 to 20 months. Numerous studies that have real world studies and phase 2 data shows that we can get a survival somewhere around 21, 22 months and 17 to 21 months, which is actually very good for our patients. And these are the real world studies. And in the second line, we also have the option of oral metronomic therapy. So, Professor Su, do you use oral metronomic therapy in Taiwan?
Yeah, we use the monotherapy with the pembrolizumab in Taiwan, but we don't use nivo more in Taiwan because they are not approved by our insurance.
No, I'm talking about oral therapy, sir. Like we use methotrexate, celecoxib, allotinibir in India quite a lot. So, do you use such things in oral cavity cancer, sir, in the second line and beyond?
And we use the pembrolizumab monotherapy as second line, and we use standard dose, and we don't use low dose as used. Yeah.
Okay. You don't use low dose immunotherapy, right? Again, that is something that we use very commonly now in India because we feel very comfortable and we have seen good responses even with low dose. So that is again something which my fellow panelists, I think, would agree with me that using low dose immunotherapy does work, and we all believe in this. Dr. Satish, your thoughts on low dose immunotherapy, sir?
Yeah, like definitely is a very good thing because cost was a major issue. That's what we started like using this low dose immunotherapy from fast almost more than 1 year. We are getting a very tremendous response in head and neck tumor. And we started using in even other malignancies, so Vegas and other malignancy also we started using. But head and neck is I'm very happy that like those are cost is a major factor. At least along with this, we can easily comfortable we can use it. And toxicity is not a major issue at all. Like when you're using metronomic therapy also along with the low dose immunotherapy you're using, those are already failed to multiple line of treatment. Otherwise, they can use it easily with the taxane-based chemo with the low dose method. Yeah, even first line, even second line, various we can use it in our low dose neuro we are using very frequently now. Yeah.
Dr. Sanket, any experience on this oral metronomic therapy? Just last thoughts. This is the last slide, I think. So your
Yeah,
thoughts on?
actually, yeah. I mean, practically speaking, most of our patients are resource constrained, and we use oral metronomic chemotherapy for most majority of the patients. But now, with the advent of this low dose immunotherapy, it's very interesting and promising. And like Satish sir said, we are including those patients also in the clinical trials. And I actually used there's an ongoing patient, is actually a 70-year-old. He was started on TPEX and there was no response and he was symptomatically getting bad. And then I put him on oral metronomic and low dose nivolumab, and he's actually doing pretty well, and he's happy with there's not much of a side effect profile, and I'm really happy with that. I don't have too much of experience with too many patients, but I like where this is going.
Yeah. Okay. So this was again discussed by Professor Su, this treatment sequence, and basically what it shows that the median overall survival is similar. It is not inferior whether you go with cetuximab followed by IO or IO followed by cetuximab, but the response rates are definitely better with cetuximab. So the patients are happier, I think, with the above sequence rather than the below sequence. And in summary, we have to see all these factors. We have to individualize the tumor site location, the tempo of the disease, the biomarker status. All these factors are important. We have to individualize our cases. An early response is something that we all want of our patients. It provides better outcome. And starting with cetuximab, probably this is most important. And cetuximab plus chemo followed by immunotherapy can give a higher survival. We have seen this with numerous real-world evidences as well as trial data. So also there might be some increase in the PDL expression when cetuximab is used in the first line. And therefore, with the extreme subgroup analysis and real-world evidence, we can use this in our day-to-day practice. Excellent discussion that has happened. I thank all my panelists and Professor Su especially for contributing so much in this discussion. With that, I hand it back to the organizers. Thank you.
Thank you so much, sir. Thanks a lot for the wonderful moderation, and thanks a lot to the esteemed panelists as well. A wonderful session overall, lots of insights for us to take back through. With this, I would like to invite Dr. Shekhar Patil. So just for a few words as a conclusion and a summarization of today's session, sir. Over to you, sir.
Yeah, thank you. Thank you. First of all, thanks to the Merck people for having me be a part of this interesting webinar. And as Dr. Professor Chu Su has brought so many important points in his discussion. And as we all know that this recurrent head and neck cancer is our major problem in our day-to-day practice. And if you want to get an immediate relief of the symptoms, because majority of time you got locally advanced, locally recurrent, as Dr. Professor Chu Su brought a very important point that better to use cetuximab based along with some systemic chemotherapy like extreme or TP extreme trials. So we can get a better response, faster response, and patients can have a symptomatic relief. So later on, if you follow up with any further progression with immunotherapy in the second line, you are going to improve even the overall survival also. So he brought a very important points, except in a very small situations where we feel that the patient has got a metastatic disease, a low volume disease, PD-L1 is high, and is less symptomatic, less aggressive, then going for immunotherapy upfront may also be a good idea, and that too along with some chemotherapy, systemic chemotherapy. So I think sequencing plays a very important role in overall improvement in the responses, improving the quality of life, and also in improving the overall survival. So in that direction, I think today's meeting was very informative, and I learned a lot of things from all my panelists and the moderator and the Professor Chu also. Once again, thank you. Thanks to Merck for making me be a part of this program. Thanks.
Thank you. Thank you for your comment.
Thanks a lot, Professor Su. Thank you for your valuable time. Thank you to all the panelists for all the insights. Thanks
Thank
a lot.
you. Thank you. Good night.
Good evening. Thanks a lot. Good night.
Good evening. Bye-bye.